What I'm going to show, to describe today, is the case of a 64-year-old man that I met in 2010. This gentleman was referred to me by the urologist after a surgical orchiectomy that was done due to the sudden appearance of a testicular painless mass that was rapidly enlarging. At the ultrasound examination, this was solid mass, so the decision to remove and to send to the pathology was taken. The orchiectomy was done, and the histological findings was that of a diffuse large B-cell lymphoma of the testis that was CD10 negative, BCL6 positive, and MAM1 positive, and with a proliferation index of 50%. At the pre-surgical assessment, the contralateral testis was negative, as well as laboratory exams that were normal, and LDH was within normal values. When I saw the patient, I collected his history, and his past history was significant for a combined familial hyperlipidemia that was treated with statins. But the patient also experienced a major cardiac event 3 months before lymphoma diagnosis. He had a myocardial infarction that was treated with an angioplasty and the positioning of medicated coronary stents in the circumflex and marginal coronary branches and in the anterior interventricular right coronary. Soon after the angioplasty, double disaggregation therapy was prescribed, and the patient was still taking acetylsalicylic acid and clopidogrel treatment. After the myocardial infarction, cardiological assessment was also done, showing good ejection fraction, estimated and calculated at 50%, but also showing a reduced kinesis of the inferolateral basal heart wall. We started and we prescribed a full staging procedure, including CT scan of the head, chest, and thorax, FDG PET scan, bone marrow biopsy, laboratory tests, and we also prescribed a new cardiologic assessment and a brain MRI, and we discussed it with the patient the indication of performing a cerebrospinal puncture for diagnostic purposes, that however we decided not to perform due to the high hemorrhagic risk associated with the treatment, with the antiaggregant treatment that the patient was taking due to the recent myocardial infarction. The staging was positive at the mediastinal level due to the appearance of enlarged hypermetabolic lymph node, both at CT scan and PET scan, that led us to conclude for a final diagnosis of stage 4A diffuse large B-cell lymphoma with testicular involvement. The IPI of this gentleman was 2, and the functional status of this patient was defined as frail due to the recent ischemia of the heart. So we had to decide about the treatment, and we discuss with the patient about the treatment option. The treatment mainstay of a patient with a testicular lymphoma or with a systemic lymphoma with testicular involvement had to include chemoimmunotherapy with R-CHOP, conventional R-CHOP treatment, prophylaxis of a central nervous system, and contralateral testis irradiation. In the treatment decision, however, we had also to discuss with the patient the risk of a conventional treatment, mainly the risk associated with the use of anthracycline in a patient with recent myocardial ischemia, and the hemorrhagic risk associated with intrathecal prophylaxis of CNS relapse that was usually done with intrathecal methotrexate, while there were no contraindication to the contralateral testis irradiation. The decision was then to treat the patient with curative intent, and given the risk associated of a cardiac toxicity with conventional doxorubicin, we decided to substitute the conventional doxorubicin with an unpegylated liposomal encapsulated version of the same drug, keeping the same dose of 50 milligrams per square meter in the so-called R-COMP regimen. And instead of performing intrathecal prophylaxis of systemic nervous system relapse, we decided to include in the treatment program 2 infusions of IV high-dose methotrexate at the dose of 3 grams per square meter. The treatment was started and was regularly conducted. We administered 6 cycles of our CHOP chemotherapy and 2 doses of methotrexate that were given after cycle 1 and after cycle 6. At the end of treatment, we performed a staging assessment that did not show any evidence of persistent disease and allowed the definition of a complete remission in this patient. Also, cardiac function was monitored during the treatment at cycle 3 and cycle 6, and we didn't show any toxicity at cardiac level. And the patient at ultrasound assessment, bidimensional echocardiogram assessment, maintained his cardiac function unchanged compared to the baseline findings. The ejection fraction assessed at the end of treatment was still 50%. We then started a follow-up program with quarterly assessment of cardiac function. Unfortunately, this patient, 8 months after treatment end, experienced a new relapse. The relapse was at the subcutaneous level, left leg, in the pretibial region. A round and enlarged mass appeared that was painless but was hard in consistency. We sent the patient to dermatological consultation. A new biopsy was done and the relapse was confirmed with the histology exam. The diagnosis was still that of diffuse large B-cell lymphoma, similar to the one that we saw initially. A full staging was repeated with the CT scan and PET scan, and the only lesion were found at the pretibial level. Another satellite lesion in the same leg was found, and also a lymph node hypermetabolic enlarged lesion was found in the left iliac site that allowed us to conclude for a stage 4 relapse. Then we had to start a new treatment and discuss it about the possible option with the patient. We initially started with a rituximab cisplatin gemcitabine combination that we administered for 1 cycle. After the cycle 1, we had to substitute cisplatin with carboplatin due to the occurrence of neurotoxicity. The patient received a total of 3 cycles. When we decided to perform a restaging of the disease, and unfortunately we didn't find any major response. The leg lesion remained stable without any change, while the satellite lesion disappeared and also the iliac node disappeared. But the conclusion was that of a lack of response or refractory disease. We concluded that the patient at that time was not eligible to the initial plan of intensified treatment with autologous stem cell transplant, and then we decided to address the patient to local radiation on the leg, and immediately after radiotherapy we decided to start a lenalidomide monotherapy treatment. The patient received radiotherapy. During radiotherapy the lesion started to improve and continued to improve during the subsequent months. Immediately after treatment, after radiotherapy, we also started lenalidomide monotherapy, initially at a dose of 25 milligrams. The dose was then reduced to 15 milligrams because of an infectious event occurred after cycle 1. 6 cycles of lenalidomide were conducted that were quite well tolerated by the patient. At the end of treatment, we performed a new staging procedure that was negative and allowed us to conclude for a complete response to the treatment. The treatment was then interrupted in agreement with the patient, and the patient, I met the patient very recently, 20 months after treatment, salvage treatment stop, and the patient is still in complete remission, in good condition, and the continuous monitoring of cardiac function didn't reveal any problems in the heart, that maintained a good function regardless the major event that he experienced 3 months before the diagnosis of lymphoma. So the case I presented today I think is important for 3 major educational points. First, the problem of testicular localization of lymphoma, which is a rare localization of this disease. Then the need of prophylaxis of central nervous system relapse in patients with diffuse large B-cell lymphoma, and finally the problem of comorbidity, in particular cardiovascular comorbidity, in a patient that also has a lymphoma that is a curable disease.